We rely on our hips so much, don't we? That incredible ball and socket joint powering pretty much every move we make.
Absolutely. But it's easy to forget how vulnerable they can be,
Mm.
especially, during adolescence.
Exactly. And today we're taking a deep dive into a condition that specifically affects this age group. Slipped upper femoral epiphysis, or SU as it's known.
Mm-hmm. SUFE.
And learner, just for you, this session is really laser focused to help you nail down the key details for your upcoming revision.
Yeah, that's the plan. We're going to pull apart all the essential information on SE, trying to make sure it really sticks with you.
Good.
So, put simply, SUA is where the growth plate at the very top of the femur, the thigh bone, well, it becomes unstable and the head of the femur actually slips.
Slips off.
Kind of, yeah. And this typically happens in those rapid growth years, usually between 10 and 15 years old.
Right. So our mission today is to basically dissect SE into clear, memorable chunks, ensuring you feel totally confident with your understanding and, importantly, your recall.
Exactly. We'll be navigating through those revision notes, pinpointing exactly what you need to know.
Okay, let's get straight into it then. What fundamentally is slipped upper femoral epiphysis?
Okay. So, at its heart, SEOFE is a hip disorder we see in adolescents. The top of the femur, the femoral head, it gets displaced
Displaced how?
because of a slip right at the growth plate that's also known as the physis, or the epiphyseal line of the upper femur.
Got it.
And the slippage leads to the common signs you'd expect. Pain in the hip, often felt in the groin, or sometimes even down in the knee, which can be confusing.
Yeah, that referred pain.
Definitely. Plus a noticeable limp and a limited range of motion in the hip joint itself.
And I noticed the revision notes mention different ways SIFE can present clinically. Could you walk us through those different types?
Absolutely. We can sort of categorize GUFE based on how quickly the slip happens. So first there's the pre-slip stage. Yeah. Here, the growth plate, that epiphyseal line, it might look a bit wider on an x-ray, maybe a bit irregular, but there's no actual slippage yet, just sort of warning signs.
Okay.
Then we have acute SUFE. This is a sudden, pretty severe slip, and it accounts for about 10 to 15% of cases.
Right, sudden.
Vary. Then there's acute-on-chronic. This is where you get a sudden slip happening on a hip that has already been experiencing a more gradual chronic slip. It's like a sudden worsening.
Ah, okay. Building on an existing problem.
Precisely. And the most common type, making up around 85% of cases, is chronic SEFE. Here, the slip develops really slowly, progressively, often over weeks or months.
Right, that makes sense. And the notes also talk about stable versus unstable slips. Why is that distinction so important?
Ah, yes. It's crucial. Really crucial, because it tells us about the severity and, importantly, the potential risks involved.
Okay.
So in a stable slip, which is thankfully more common, about 90%, the patient can actually still walk. They might be in pain, limping, but they can bear weight. And importantly, these stable slips have a lower risk of a really serious complication called avascular necrosis, or AVN, which we'll definitely come back to.
Okay, lower risk and stable. And
Yeah.
unstable.
Well, unstable slips, they make up the other 10% or so. This is when the patient literally cannot put any weight on the affected leg. It's too painful, too unstable.
Right, unable to walk.
Exactly. And these are much more concerning because they carry a significantly higher risk of that avascular necrosis.
Okay, that distinction is crystal clear now. And finally, for the definitions, the notes mention classifying the slip based on x-rays. How does that work?
Yeah, that's the radiographical classification. It's actually quite straightforward. It just describes how far the femoral head has slipped relative to the neck of the femur as you see it on the x-ray.
So just measuring the slip.
Pretty much. It's graded from mild, grade 1, where there's just a small amount of slippage, up to moderate, grade 2, and then severe, grade 3, which indicates a really significant displacement. So this classification just helps us quantify the extent of the problem, really. Helps guide treatment, too.
Got it. Okay, let's shift gears a bit. What might actually be causing SU in the first place? The notes say the exact cause isn't known, which, as you said, feels like classic exam fodder.
You're absolutely right. It often is. And while we don't have a single definitive cause, like a specific gene or bug, we believe it's usually a combination of factors.
Okay.
The notes highlight a few key players. First, a general weakness of the growth plate itself. It's just not as strong as it should be during that period.
Right.
Then, those significant hormonal shifts happening during adolescence. Remember, that's a period of really rapid growth, so things are changing quickly.
Yeah, hormones are all over the place.
Exactly. And finally, increased mechanical stress on the hip joint. Think of it like I don't know, a structure under strain. If the foundation's a bit weak or there's too much load, things can give way.
And are there specific conditions or factors that seem to pop up alongside SUFE more often?
Yes, the notes point to a couple of important associations. Firstly, certain endocrine disorders, things like hypothyroidism or growth hormone issues, seem to increase the risk.
Okay.
Secondly, and this is a really, really significant one, obesity. There's a very strong link.
Right. You mentioned mechanical stress.
Precisely. It's thought that the extra weight puts significantly increased pressure, increased shear forces across that vulnerable growth plate, making it much more likely to slip.
And it's worrying, isn't it? The notes mention we're seeing it more often in younger.
It is worrying. We are seeing a rise in incidence, younger age of onset, and more bilateral cases, too. And it seems very likely this is linked to rising childhood obesity rates. It's not just a coincidence. It really suggests that increased mechanical load on these developing hips is a major factor, possibly worsening any underlying growth plate weakness.
So, no single cause, but a strong suspicion on weak plates, hormones, and mechanical stress, especially from obesity. Got it. Now let's tackle the risk factors systematically. Your notes have a helpful list. Is there a way we can make these really stick for recall? You mentioned a mnemonic.
Definitely. How about we try a Bodhi mates?
A Bodhi mates. I like it. Okay, let's break that down so it's crystal clear for everyone listening.
Right. So A is for adolescents, particularly those rapid growth spurts we keep mentioning. That's the key time window.
Makes sense. B.
B is for boys. The notes are clear. Male gender is more commonly affected, about 1.5 times more often.
Okay.
O is for obesity. We've hammered this one, but it's vital. Remember, over 80% of diagnosed children are obese. It's a huge factor.
Massive.
D can remind us of dysplasia, specifically things like renal osteodystrophy causing bone dysplasia. Less common, but still a risk.
Okay.
E points to those endocrine disorders we mentioned, hypothyroidism, growth hormone abnormalities, and the like.
Got it.
M is for mechanical factors. Now, this could be local trauma, although often it's more about that chronic stress, like from obesity itself.
Right, the load. A again.
A again, yes. This time for affected family members. There seems to be some genetic or familial predisposition, though it's not fully understood.
Okay. T.
T reminds us of treatment history. Specifically, things like previous radiation therapy or chemotherapy can weaken the bone and growth plate.
Right, and S.
And finally, S could stand for septic arthritis, or perhaps more broadly, neglected inflammatory conditions around the hip.
Okay, Bodhi mates, adolescent, boys, obesity, dysplasia, endocrine, mechanical, affected family, treatment history, septic arthritis. It's really helpful.
Hopefully. Just a way to peg those key factors in your mind.
Brilliant. Now, zooming in a bit, what's actually happening at the tissue level? What's the pathophysiology here?
So, at the core, as the notes explain, it all starts with that upper femoral growth plate weakening. For whatever reason, or a combination of reasons, it loses its structural integrity. This weakening then leads to the key event, the slip and displacement of the femoral head relative to the femoral neck below it.
You used the ice cream analogy before.
Yeah, like a scoop of ice cream starting to slide off the cone. The femoral head is the scoop, the neck is the cone. If that connection, the growth plate, weakens, it starts to slip downwards and backwards, usually.
And what's the big danger when that happens?
Well, the really critical consequence of this displacement is the potential disruption of the blood supply to the femoral head. Those little blood vessels running up the femoral neck can get stretched, kinked, or torn during the slip.
And that leads to?
If that blood supply is significantly compromised, it can lead to a vascular necrosis, AVN. That's a very serious complication, where the bone tissue in the femoral head actually dies because it's starved of oxygen and nutrients.
Not good at all. And just to reiterate, the notes are clear that the exact reasons why the growth plate weakens aren't fully understood. It's complex.
Exactly. Multifactorial is the key word. Now, if a young person comes in with hip pain and a limp, what else should be on the radar? What are the main differential diagnoses doctors need to consider before landing on SV?
Right. What else mimics it?
That's where the differential diagnosis list comes in. It's important to think broadly. We can kind of group them. Firstly, you've got to consider traumatic injuries, like actual hip fractures, although the mechanism might be different.
Okay.
Then there are infectious causes. Things like hip joint infections, osteomyelitis, bone infection, or septic arthritis, joint infection, can cause severe pain and limping.
Right. Infection is serious.
Definitely. Inflammatory conditions are another group, so juvenile inflammatory arthritis, for example. And a really common one, often a bit of a diagnostic challenge, is transient synovitis.
Ah, yes, the irritable hip.
Exactly. A temporary inflammation of the hip joint lining, usually in younger kids, but can overlap. It causes pain and limp, often an antalgic gait, that's where you walk funny, to reduce the pain on the bad side. Any of these can cause that.
So lots of causes for that limp.
Absolutely. And finally, you need to think about other developmental issues. Things like Perthes disease, which also affects the femoral head's blood supply, but typically in younger children, and maybe even missed developmental dysplasia of the hip, DDH, presenting later. Wow, okay, so a thorough history, examination, and the right investigations are crucial to sort through that list.
Precisely. You need to rule those other possibilities out to be confident in the SE diagnosis.
That's a really helpful rundown of the differentials. Now, let's talk numbers. How common is SUC, really? What does the epidemiology tell us, particularly here in the UK?
Well, in the UK, the overall prevalence is estimated at approximately 1 in 50,000 children, which, sounds rare but adds up.
Okay.
And as we've already touched on, it's definitely more common in boys, particularly during those early adolescent years, think 12, 13, 14.
And you said it's the most common hip disorder in teens. Yes. Overall, SUFE is actually considered the most common hip disorder in adolescents. The figure quoted is around 10.8 per 100,000 children, typically hitting between the ages of 8 and 15. And the notes make a point that it can sometimes be missed initially, maybe dismissed as growing pains or a pulled muscle.
Right, especially the chronic type, perhaps. Are there any other interesting patterns in who gets it?
Yeah, a couple of things. The left hip seems to be affected slightly more often than the right, for reasons we don't fully understand. And bilateral cases, meaning both hips are affected, are actually quite common. The range is wide in the notes, 20 to 80%, but it happens often enough that you always need to check the other hip.
Wow, 20 to 80% is a huge range.
It is, suggesting maybe different studies or populations. But the point is, always check both hips. And while it's about 1.5 times more common in boys overall, the notes point out that those dangerous unstable slips are actually equally common in girls.
Oh, interesting. Okay.
But perhaps the most significant trend epidemiologically is what we mentioned earlier. We're seeing a rising incidence. It's happening at a younger age on average, and there's an increasing frequency of bilateral cases.
And that links back to obesity.
The notes directly link this trend to the rising rates of childhood obesity. It really reinforces that crucial connection. It's a major public health concern reflected in this specific condition.
It really is. And do the notes mention race?
They briefly mention that incidence can vary among different racial groups, but they don't provide specific UK data on that here.
Okay. So rising rates, younger onset, more bilateral cases, strong obesity link. That's a clear epidemiological picture. Now let's get practical. How does SE typically present when a patient actually comes to the clinic or A&E? What are the key clinical features to look out for?
Okay, the classic presentation in an adolescent is usually hip or groin pain. That's the big one. But remember, critically, it can sometimes present primarily as knee pain, that referred pain phenomenon.
Right. Always examine the hip if a child has knee pain.
Always, always. They'll also often have a limp, typically an antalgic gait, as we said, where they're trying to spend less time weight-bearing on the painful side.
Okay.
On examination, you'll often find decreased hip joint motion. The most characteristic finding here is a limitation in internal rotation, especially when the hip is flexed to 90 degrees. That's often one of the first movements to become restricted and painful.
Limited internal rotation key sign.
Definitely. And another classic sign to look for is obligate external rotation. When you flex the patient's hip passively, the leg tends to drift into outward rotation. They can't keep it straight easily.
Ah, okay. The leg just swings out on its own.
Pretty much, yeah. The onset of these symptoms can be gradual, sort of insidious over weeks or months in chronic cases, or it can be much more sudden, especially with an acute slip, and it might even follow what seems like really minor trauma, like jumping off a step.
Right. Doesn't take much if the plate is weak. And do the symptoms vary much depending on the stage, acute versus chronic?
Yes, they definitely can. In that pre-slip stage, the patient might only have very slight intermittent discomfort, maybe an ache after activity, or sometimes the findings are purely incidental on an x-ray done for something else.
Subtle.
Very. With an acute slip, however, the pain is usually severe. The patient will have significant difficulty walking or often be completely unable to bear weight if it's unstable, and there will be a really marked limitation in hip movement in all directions.
Much more dramatic.
Absolutely.
Huh.
In acute-on-chronic, you'll typically hear a story of some background grumbling hip or knee pain for a while, and then a sudden event leads to a sharp increase in pain and loss of function.
Okay.
And then in chronic SUFE, which is the most common, the symptoms might be milder, maybe intermittent pain in the hip, groin, thigh, or knee. There's usually a persistent limp often worse with activity, and that progressive loss of internal rotation.
So a spectrum of presentations.
Yeah.
And recapping the exam findings, what are the absolute must-not-miss things to look for that should scream, consider SUFE?
Okay, key takeaways for examination. First, always ask about and consider knee or distal thigh pain as potentially originating from the hip. Don't get caught out by referred pain.
Rule number 1.
Rule number 1. Second, carefully assess hip range of motion, specifically looking for that reduced internal rotation when the hip is flexed. This is often described as a highly sensitive sign. And check for that obligate external rotation during flexion too.
Okay.
In more chronic cases, you might also observe some leg length discrepancy, with the affected leg appearing slightly shorter, or even some visible wasting of the thigh muscles, quadriceps atrophy, due to disuse.
Right. Muscle wasting takes time.
Exactly. Recognizing these signs promptly is absolutely crucial for getting that early diagnosis and referral.
Definitely. So if SUV is suspected based on these clinical features, what investigations are needed to confirm it?
Right, investigations. X-rays are the absolute cornerstone. They are the primary diagnostic tool.
What views are needed?
Typically, you need good quality AP, androposterior, and frog leg lateral views of both hips. Comparing sides is really important.
Okay. AP and frog leg lateral, and what are we looking for?
The main thing is evidence of the femoral head being displaced relative to the femoral neck, usually posteriorly and inferiorly. On the AP view, a subtle sign is Klein's line. You draw a line along the superior edge of the femoral neck. Normally, this line should intersect at least a small portion of the femoral head. If the line falls completely outside the head, that suggests a slip.
Klein's line. Okay. Useful tip.
Yeah. On the lateral view, the slip is often much more obvious. You can see the head displaced posteriorly relative to the neck. The notes also describe some potential early changes you might see even before a definite slip. Maybe some widening of the joint capsule indicating an effusion, and an irregular and widened appearance of the epiphyseal line itself, and perhaps some decalcification along the epiphyseal border.
So subtle signs might be there early on.
Exactly. Sometimes it's just that the epiphyseal edge doesn't quite overlap the necks properly anymore, suggesting it's starting to move.
Got it. And what about other imaging? Ultrasound, CT.
Well, ultrasound isn't typically used for the primary diagnosis of SUFE itself, but it can be useful occasionally to detect a hip joint effusion, that fluid buildup, which might be present.
Okay.
CT scans are generally reserved for more complex situations. For example, if we need really detailed planning before surgery, maybe for a complex osteotomy, or perhaps if the x-rays are inconclusive for some reason and we need to better look at the 3D anatomy to fully define the extent and orientation of the slip, but it's not routine.
So X-rays are king for diagnosis. Once SUFE is diagnosed, what's the standard management approach here in the UK?
The notes are very clear on this, and this is key for your exams. Surgery is the primary treatment in the UK for SUFE, almost always.
Right. No messing about.
No. The main goal of surgery is to stabilize the hip joint and, crucially, prevent any further slippage from occurring. We need to stop it getting worse.
And what are the main surgical techniques used to achieve that?
Okay. The notes detail two main options. By far the most common, especially for stable slips, is single in situ center-to-center screw fixation.
In situ screw fixation? Sounds straightforward.
It's a well-established, effective technique. It's relatively minimally invasive, usually done through a small incision on the side of the thigh. A cannulated screw is inserted up the femoral neck, across the growth plate, and into the femoral head to physically pin it in place and stop it slipping further. It's often used regardless of the initial degree of deformity in stable slips.
Okay, pin it in place. What's the other option?
The other main option mentioned is open reduction, which might involve a femoral neck osteotomy. This is a more complex procedure where the surgeon makes an open incision, potentially realigns the femoral head more anatomically if it's significantly displaced, and then fixes it, possibly after cutting and repositioning the bone. That's the osteotomy part.
When would they do that?
The notes say this approach is being used perhaps increasingly, particularly in acute, less severe slips, with the specific aim of trying to restore more normal anatomy and reduce the long-term risk of developing femoroacetabular impingement, FAI.
Ah, FAI. Explain that again briefly.
Yeah, FAI, femoroacetabular impingement. It basically means the shape of the ball, femoral head, and socket, acetabulum, isn't quite perfect after the MSU, maybe due to the residual slip or the way it healed. This abnormal shape can cause the bones to bump or impinge on each other during movement, leading to pain, cartilage damage, and eventually arthritis. So correcting the alignment more precisely with an open reduction might help prevent this down the line.
Okay, makes sense. More complex surgery for potentially better long-term mechanics. And what about non-surgical treatments? Is there any role for just rest or physio?
Well, the notes indicate that non-weight bearing is absolutely crucial immediately upon suspicion or diagnosis, before surgery. And physical therapy certainly has a role, but mainly after surgery for rehabilitation, regaining strength, motion, and function. It's not a primary treatment to fix the slip itself.
Right, surgery first.
Exactly. And it cannot be stressed enough, as your notes highlight. If you suspect SUFE, an immediate referral to orthopaedics is absolutely essential. Time is critical. Delay can increase the risk of further slipping, AVN, and poorer outcomes.
So, urgent referral. What should the patient do while waiting?
The patient should be made strictly non-weight bearing on the affected leg. They need to avoid any movement or rotation of the leg as much as possible. They must not walk on it. Crutches or a wheelchair immediately.
Okay, strict instructions. And what about older treatments? The notes mention things that are not recommended anymore.
Yes, important to know what not to do. The notes explicitly state that attempts at closed reduction, trying to manipulate the hip back into place without surgery, and putting the patient in a hip spica cast are no longer recommended. These approaches were found to potentially increase the risk of complications, particularly AVN, so they've largely been abandoned in favor of surgical stabilization.
Good to know. Avoid closed reduction and spicas.
Definitely. And finally, it's just worth noting that research is ongoing. There's a Cochrane review mentioned, looking at comparing different surgical techniques and also evaluating non-operative strategies, although surgery remains the standard currently.
Right. So early diagnosis, non-weight bearing, urgent referral, and surgical stabilization, usually with a screw. That seems to be the pathway. What about the long-term outlook? What's the prognosis generally like for these kids?
The prognosis, as the notes explain, is quite variable. It really depends on several key factors.
Such as?
Primarily, the severity of the initial slip. Mild slips generally do better than severe ones. Also, how quickly the diagnosis was made and treatment-initiated promptness matters. And of course, how effective the treatment was in stabilizing the slip and preventing complications.
Look, overall.
Overall, with timely and appropriate management, particularly for stable, mild to moderate slips, the outlook is generally pretty good. Many patients can achieve a good recovery and return to near-normal hip function and activity levels.
That's encouraging. But you mentioned complications impacting prognosis.
Yes, unfortunately, complications can occur, and they definitely influence the long-term outcome. The notes list several potential issues, which we should probably detail next. These include things like hip joint incongruity, the joint not fitting smoothly, a vascular necrosis, AVN, that big one, the loss of blood supply, and the risk of developing early onset arthritis, specifically osteoarthritis of the hip, later in life.
Right.
The notes do reiterate, though, that mild to moderate slips generally carry a better prognosis than severe or unstable slips. And again, they underscore the critical importance of early diagnosis for achieving better outcomes, and also mention the goal of preventing that femoroacetabular impingement, FAI, to improve long-term results.
So, catch it early, treat it effectively, minimize those risks. Let's delve into those potential complications properly now. What are the main ones to be aware of?
Okay, complications. As we've mentioned multiple times because it's so important, a vascular necrosis, AVN, of the femoral head is a major concern, especially with unstable slips or delays in treatment. That death of bone tissue can lead to collapse of the femoral head and severe arthritis.
A really bad outcome.
The worst, really.
Yeah.
Then there's hip joint incongruity. If the slipped epiphysis doesn't heal in a good position, the ball and socket just don't fit together smoothly anymore, leading to abnormal wear and tear, pain, and restricted movement.
Okay.
Closely related is femoroacetabular impingement, FAI, which we discussed. That abnormal contact between the bones due to the altered shape can cause pain and damage the cartilage and the labrum over time,
Leading to?
leading potentially to early onset arthritis or osteoarthritis of the hip. SUFE is a known risk factor for needing a hip replacement at a younger age than usual if significant arthritis develops.
Right, long-term consequence. What else?
Other potential complications listed in the notes include leg length discrepancy, if the slip affects growth significantly or isn't corrected well. Chondrolysis is another nasty one. It's a rapid and severe destruction of the articular cartilage in the hip joint, leading to pain and stiffness. Its exact cause isn't fully known, but it's a recognized complication of SUFE and its treatment sometimes. And finally, there's always a small risk of recurrence or progression of the slip, especially if fixation isn't adequate, or sometimes development of FUFE in the other hip later on.
That's quite a list. Really highlights why this needs careful management.
Absolutely. Understanding these potential complications is key to counseling patients and families and for long-term follow-up.
Definitely. Okay, so to bring our deep dive into slipped upper femoral epiphysis to a close, what are the absolute key high-yield things our listener, the learner, should really lock down for their revision?
Right, let's summarize the essentials. Remember the definition. It's that slipping of the upper femoral growth plate, the epiphysis leading to displacement of the femoral head, crucially in adolescents.
Got it.
Keep those risk factors firmly in mind. Hopefully our mnemonic, Abodi mates, helps there with a really strong emphasis on the link with obesity. That's critical.
Obesity, obesity, obesity.
Pretty much. Understand the importance of early diagnosis. Recognize those clinical features, the limp, the hip grow and knee pain, the limited internal rotation, and know that X-rays, AP and frog lateral, are key. Remember Klein's line.
Clinical signs and x-rays.
Know that surgery is the primary treatment in the UK, usually in situ screw fixation, aimed at immediate stabilization. Non-weight-bearing and urgent referral are vital first steps.
Surgery is key.
And finally, be sure to recall the potential complications, especially avascular necrosis, AVN, as a major risk, particularly in unstable slips, but also chondrolysis, FAI, and long-term osteoarthritis.
Excellent summary. Really hits the main points.
Hopefully that covers the core knowledge needed.
I think it does. And on that crucial read about complications and the importance of getting this right, learner, we really hope this deep dive has equipped you with a clear, confident, and high-yield understanding of SENFI as you gear up for your MSRA.
Yeah, absolutely.
And remember, for even more valuable resources, practice questions, and detailed notes to support your ongoing learning and revision, make sure you check out PastthemSRA.com and also FreemSRA.com.
Definitely worth a look.
Thanks so much for joining us for this deep dive today. We wish you the very, very best with your studies and your exams.